So thank you everyone for following our directions and giving us all a ton of questions. So keep them coming. Okay, so would love to hear from anyone on this question first. Some would say that a significant driver of poor youth mental health is technology itself. Does that add complexity to how we use these different technologies during treatment? So just to give context, we have about 30 questions. So I don't think we're gonna get to all of them, but brevity is a virtue.
Could I just briefly say, because there are American Academy of Pediatric recommendations on children's use of tools. So actually the children are on the device just for the Yummy Yucky game, and the videos are 30 seconds long. All of our interventions, insights, are things to do non-digitally, because obviously that's what is best for children.
Yeah, and I'll just jump in as well. So another hat I wear is doing an exposure-based treatment for frustration, whereby the most common frustration induction that we practice over and over again is having a child stop playing a game with iPad or some. So there is a bit of irony that half my time I'm spending developing intervention. So what we do is very clearly talk about when to use it, when not to use it, and that there aren't any games on what we'll be providing. And so the games is oftentimes the hook, the social media, all of that is off the devices we use.
And if I could just add, from a clinical perspective, when we're working with our families, especially ages 10 and up, we teach the parents to put their cell phones in a box in a way when the kids are at home so that they could model. You want the kids to talk to you and get off their games, put your phones away too.
Yeah.
Thank you. A trusting relationship with a therapist has been shown to be an important component of effective child and adolescent psychotherapy. How can digital solutions facilitate a supportive relationship within which evidence-based treatments can be administered? So maybe we'll start with Tony with that one because it's relevant to telepsych.
Yeah, it's a really good question because when we think about interventions using technology, we often think about those replacing traditional treatment. But I think increasingly as we think about augmenting the clinical encounter, in particular the direct patient encounter video visit during a blizzard or an impromptu visit that couldn't happen otherwise during a vacation or some other kind of distant event. These are the kinds of things that can really be used to augment the already existing relationship.
A question for Helen. What are the two biggest lessons you learned in developing easy-to-use, user-centric software apps?
So really the first is the collaboration with colleagues, and particularly what I've so enjoyed is learning how to think like an engineer, and at the same time having my engineers learn how to think like a child psychiatrist, so that I have found, and I think my team has, thinking about what's the problem, how are we proposing to solve it, what's the story that we're going to do that, you know, we'll know that we're done with that if it's solved that problem, and then do user testing, has really transformed my thinking. So I run a big department of 110 full-time faculty. We're now using many of the approaches like workshopping with a divergent and convergence thinking design workshops when I'm launching new initiatives that have nothing to do with technology, but they've really become great ways to frame and also to build consensus. I think the other piece is to really just get over ourselves, and I'll really say this as an academic person, of just that, you know, we're trained, like we know what we're talking about, we'll come in the room, we know it, but to be humble and to have a sort of a querying point of view and work with your team. I've got people of all ages, all different perspectives, that we each are providing we each are bringing something to this that's going to make something much better than we can. I'll just say I've had to do a lot of work as chair. I never meet with the Wonder Lab in my fancy chair's office because I feel like that would really be emphasizing a kind of a hierarchy and roles that I have to be in a different role when we're collaborating that way.
Thank you. For Melissa, did you use a clinical survey for your irritability questions in your app? So I think this is referring to a standard, was there a standardized measure that you used?
So we very much built on existing measures. So for the irritability items, we drew heavily from the ARI. And I didn't talk about it, but we also have depression items where we drew from classic depression measures, the MSQ, I believe, MFQ, and for anxiety, the SCARED. Actually for some mood lability items, which I didn't get into, we pulled some questions from the DABA. So what we tried to do was try and, to the extent there is any type of ground truth that has some evidence support it, we tried to change those questions into in-the-moment questions.
There's several questions about parents, specifically one about learning disorders. Do you see emerging digital solutions for parents and children with mental and learning, any mental health conditions? If anyone wanted to comment on that.
I think we need to tackle each area, that it's both different domains. Although one thing I'll say with the platform we're building, I showed you picky eating, we're doing tantrums, anxiety, and sleep next. These are all interrelated. Disorders and challenges do not present singly. So I think the challenge of how we assess across multiple domains over time for an individual, but also in the context of development, is going to be both our opportunity and challenge. And I hope that we can move away from single purpose types of apps or tools, not apps, to things that are more integrative and assess the whole child within the family context.
Thank you. And thank you, everyone, for these wonderful questions. We're not going to get to all of them, unfortunately, but they are wonderful. So difficult to choose. For Tony, CMS does not pay for telepsychiatry for places that are not health professional shortage areas. Any advice on how to make it financially sustainable for places with many Medicare patients that aren't in these areas but still have limited access to care?
Wait. There is some proposed change to the Medicare CMS reimbursement rules that has been proposed this year. It's not a fast process, but there is some push to do that. But it really, it uniquely hits Medicare population and the elderly, which is very difficult because the home-based use case for someone who is infirmed or anxious about leaving the house unsupervised or unattended, these are very, very serious concerns.
Yeah, the care needs to be as good as in-person care. So there needs to be an emergency response. To your point, it can't be that so in essence, it's not a panacea. You still need to account for everything you would if you were in the office with a patient. For Anne-Marie, are there any is there any longitudinal data available on the efficacy of any tech-based early CBT intervention models, or are we still stuck on the feasibility analyses of these interventions?
That's a good question. There are a number of investigators when we talk about early childhood. Is that what we're asking? Or well, let me just say there's a number of investigators who are looking at and have been studying the delivery of CBT, for example, through an interactive program like the Camp Copilot for anxious kids. There's plenty of data over the long term with long-term follow-up that Phil Kendall and Mania Khanna have for that. And those are children 7 to, I think, 14 years of age, and then also there's the parents, parent education program too. John Comer at Florida International University has been looking at the delivery of parent-child interaction therapy, which is an evidence-based treatment for very young children, 3 to 7 years of age, with acting out behaviors, also anxiety. And he's been delivering that through telemedicine, where the parents are in the home and he has a bug in their ear and he's coaching them. So he should have data, if it's not published, coming out. And then I think there's a lot of data that Doug Woods and the group that works with kids with Tourette's and tics have, again, for distance intervention through the internet, plus other programs that are out there too. I think you might have to look in the psychology journals for some of these, like Journal of Clinical and Consulting, and then also the journal Internet Interventions, where you'll see a lot from Scandinavia, actually, on interventions for children.
Thank you. That was great. So a lot of questions about workforce issues. In essence, this is a graying population, so the workforce of psychiatrists will only worsen. Specifically, these individuals, so there's a large population of psychiatrists who are retiring, but then also retiring early. These individuals have the capability to treat underserved patients as volunteer psychiatrists. However, most are unable to donate their time as they have resigned their malpractice insurance. Is it possible for us to mobilize this workforce? Helen?
Yeah, well, no, I don't know, but that's a great idea. And it's interesting because I've had actually a few psychiatrists who are retiring ask to work with us in this area, not necessarily in delivering care, but I think it's a broader issue of the wisdom of experienced clinicians and how we not only bring it to serve patients, but also to inform clinically appropriate and rich kinds of digital solutions.
Do you look for software engineers that are cross-trained in psychiatry, neurobiology, other relevant medical fields when looking for those to design your digital tools?
I mean, I can answer no. I think the thing is, you have to, so when we started the Picky Eating Project, our software engineers are actually in Ecuador, but they flew up. We did a week-long Inception Week, which is where we work together defining the journey map, what we were doing, how we were going to work together. And I think it's much more from my perspective how the methodology, the team-based methodology and respect with each person bringing in their expertise. Although, I've joked about this, but when an engineer says, but what about comorbidity? You're like, yes. And I'm sure they feel that same way if one of us says something about some other kind of engineering feature.
Just to echo what Helen said, I too have not used anyone with any psychiatric training or background, and in some sense, it's refreshing because they ask you the questions that you take for granted. Why are you doing this? And you kind of think, well, why am I doing it? So it actually is helpful.
Can I just say one thing? Because someone else said this. Our experience both with students and people from industry, they're so excited to work on this project. And so I do think sort of mission-driven projects that it's not that often that folks who are doing engineer and software development have that kind of opportunity. So it hasn't been difficult for us to recruit people to work with us.
Yeah, exactly. Someone is looking for a job in the audience. So last question, because we're coming up on time right now. For Tony, what is the role for telepsychiatry in regions where access to traditional in-person psychiatry isn't an issue?
Is there one? in all honesty, it's hard to imagine there being an abundance of child and adolescent psychiatry, even in a blessed area like the Boston metropolitan area in New York City. You know, the majority of child and adolescent psychiatrists live in a small swath between here and New York City, and still those are considered generally underserved areas. That said, I think that there are a number of ways that it can enhance an already existing in-person treatment by providing ease of access, additional settings for the encounters, shorter, more brief encounters as needed, some asynchronous technologies as well, which we didn't talk about, could provide between visit monitoring and self-assessment. And I think that you know, if you are in a region that's blessed with enough child and adolescent psychiatrists to really adequately treat the population, you are inevitably going to be dealing with outliers and subspecialty cases where that subspecialty consultation could be really helpful. And you know, I'm thinking specifically about autism spectrum disorder, OCD, early adolescent or childhood bipolar disorder. These are places where a lot of providers in the community may want some subspecialty consultation. So I think there's a role for it in the same way that there is in a highly resourced environment for in-person care.
Thank you so much to everyone, and thank you for a wonderful first day of this summit.